Assalamu alaikum, Honorable Chairperson, respected panelist and learned audience. Welcome you all. Very good afternoon to my presentation. At the early morning, there was a lively discussion regarding primary PCI at Hall A, and now at late evening, the session is going to conclude again with the primary PCI. And obviously, primary PCI is always rewarding. And let's have a look, or let's go through a case firstly. Our case was a female patient, 45 years, diabetic hepatitis patient, presented with a chest pain for 8 hours in NICBD, and hemodynamically she was stable. And EKG shows there is a clear-cut STEMI anterior. So the patient party was counseled regarding primary PCI, and they agreed to do so. So the cath lab was activated, and we go through transradial route. Angio shows the right system. There is a 70 to 80% stenosis at the proximal part and 50-60% stenosis at mid part. And the left system, the mid LED, from the mid LED it is 100% occluded, and the L6 also 100% occluded. So the mid LED 100% occluded from what should be done? PCI to LED, L6 and RCA. Option B, send the patient for CABG. Or option C, PCI to LED, then send the patient to CCU and stage PCI to L6 and RCA. So let's go through some evidence. Approximately 50% of STEMI patients have additional or severe stenotic lesions in non-infarct related coronary arteries. So it's a big deal, and let's go through some evidence. Shiblee trial was the first in 2015 published. They challenged the conception of conservative management of non-infarct related artery at that time, and the result favored complete revascularization, significantly lowered the rate of composite primary endpoint at 12 months follow-up. Subsequent Dynami 3 Primalty trial published in 2015 also favors the complete revascularization in STEMI patient. Then deferred versus conventional stent implantation in STEMI patient, Dynami 3 deferred trial. Sometimes the thrombus burden is a issue. So what should we do? Defer the patient to stabilize the thrombus, then again stage PCI. But this trial shows that there is no difference between the deferred and the conventional PCI. There is no difference in peri-procedural complication. Next, compare acute investigator also showed in 2017 that FFR guided complete revascularization of non-infarct related arteries in the acute setting resulted in a risk of composite cardiovascular outcome that was lower than the risk among those who were treated for infarct related artery only. So this trial also favored the complete revascularization either staged or during primary PCI. And another issue was should we do complete revascularization in shock? In patient comes with STEMI with shock. But the groundbreaking trial, that culprit shock trial, the investigator showed that it is not wise to do the total revascularization in shock patient. And 2019,
2 minutes left.
The multiple PCI MI incomplete trial. This is a big trial. Around 4,000 patients were included in complete trial, and it also favors complete revascularization in STEMI patient, usually staged superior to culprit lesion only PCI. And Shiblee trial, long-term reduction in death and MI with complete revascularization also favor complete revascularization. So compare acute 3 years, that is long-term outcome, that is also favors the complete revascularization is more beneficial in terms of outcome and healthcare cost, and 36-month follow-up. So 2018 ESC guideline, there is class 2 indication of non-ERA, that is complete revascularization of during primary PCI. And 2021 ACC AHA guideline, there is class 1 recommendation in selected hemodynamically stable patients with STMI and multivessel disease after successful primary PCI. Stage PCI of significant non-infarct artery is recommended. So go back to our cases. Wire passes smoothly and flow established in LED. Then we 2 into 15 millimeter Maverick balloon pre-dilatation done. Stent placed across the lesion. 2.7 into 2.75 into 40 millimeter or 0 taken, and it was placed across the lesion, and stent was deflated. Stent view taken, and post dilation done with NC balloon to 3.25 into 8 millimeter. And similarly the stent is well accommodated, and this is the final view, TME3 flow established. So the final view shows there is a TME3 flow and LED. And unfortunately patient was not agreed to do any further procedure, so they took discharge. So my take home message is, in hemodynamically stable patients with STMI and multivessel disease after successful primary PCI, stage PCI of significant non-infarct artery stenosis is recommended to reduce the risk of death or MI. And in selected hemodynamically stable patients with STMI, PCI of non-infarct artery stenosis may be considered at the time of primary PCI to reduce cardiac events. So thank you all, and pray for the flooded area, Sylhet and Sunamganj, and thank you all for patience hearing.